Today we're going to cover IV-IO access, Tyler Webster 2023. Objectives, cover reasons why we perform this, discuss sites available to perform intravenous access, discuss sites available to perform intraosseous access, and then cover equipment needed to perform each task. IV-IO common calls. Obviously there's more that can get this. Be on this list, but this is just a couple of the big ones: stroke, MI, seizure, full arrest, chest pain, shock, hypovolemic, trauma, multiple types. Again, does not necessarily cover the full list, is not limited to this list. Just a quick idea of things that you may be starting an IV on without a doubt. One of the things that is in the protocols that they ask for is if you do have a stroke alert or a patient you believe is having a stroke, to try and get an IV that is an 18 gauge at least. That'll be able to help the hospital. And then try not to start them just for fun. If you feel like you're going to miss, it's okay to just wait. IV-IO. Why? Why do we perform this task? Volume infusion, I think, is number one. Administer medications. Have it as a just in case. The IO specifically, if IV access is prolonged or you're unable to find an IV site. Level of consciousness, hemodynamic stability, time, and arrest. Full arrest, and then time refers to how quick this task needs to be done versus how much time do we have. It may be faster to just drill somebody than to look on someone and try and find a vein. That may end up taking a couple of minutes versus it's a little easier to find our landmarks for the IO. Contraindications and precautions. Burns or chemicals on the site of the IV or IO, fractures in the place of the IV or IO, previous surgeries, infections, and cannot find your landmarks. IV access. This is just a little map of the veins that traditionally run through somebody's arm. Each patient is going to have a slightly different map compared to this. This is not an exact science, but this is a pretty good idea of how some of these veins come in and through. I know we like to use the antecubital space where the basilic vein is and runs through. Is a very common one, as well as the cephalic vein and the median cubital vein. All of that's a part of the AC, the antecubital space. I know personally for me, I really like in the hand, the one near the thumb, the cephalic vein running near the thumb and the index finger. That's always a nice one. And then as well as right above the wrist in the cephalic vein again. Angio selection. We have two types of angios in the back of the ambulance. We have the traditional spring-loaded, spring-safetied on the left, and then the Nexivas on the right. They are slightly different in their application, but at the end of the day, it is still an angio over a needle. Here's a real quick diagram about how much fluid you can flow per minute based off of the angio size that you are selecting. This is important specifically because if we are going to be starting an IV for volume infusion, mainly having to run boluses, as you can see, we could run a full bolus in just under a minute in a 16 gauge versus in an 18 gauge, it could take 2 minutes at the 105 mLs per minute. And then in a 20 gauge, you could run a bolus in about 3.5. Then obviously it goes down from there. But the time drastically goes up. Extra equipment necessary. There's blood tubing, an infuser bag, an IV pump. It's a traditional set of primary tubing down on the bottom, or sorry, that's a piggyback tubing. A traditional piggyback tubing that goes in the IV pump. You can see with the plastic thing up on the top left there is what fits in the actual roller. There's a primary tubing if you're not running an IV pump. Start kit, gloves and PPE, HEP locks, J loops, and then an IO kit with a specific J loop in it. The IO J loop is specific to the IO, and the end of it where it connects to the hub for the patient is a 90-degree. And I was told that these are meant for more higher pressures to withstand the infuser bags and the pressure that they push through there, as well as the pressure that it takes to get it into the osseous space versus the traditional J loops. So it is definitely preferred and recommended that you use the J loop in an IO kit for the IO only and don't pull one out of the IV kit. IV sites uncommonly used. I think these are very, very few and far between. And if you're not comfortable going through these, that's fine. There's obvious risk to going outside of the sites that we traditionally go to, especially in a patient. And the patients I'm thinking are along the lines of diabetics who have poor vascularity in their peripheries due to the extent of their disease. They're just not getting good blood flow. So you may need the antecubital site, above the antecubital site in the bicep area. But again, if you're not versed in looking there, it's going to be difficult to find. Refer back to that vein map that was a couple slides ago. But with the foot and the leg sites, you really got to weigh out your cost versus benefit with starting an IV down there, because you could be creating an issue for this patient and potentially not being the direct reason that they lose a limb, but anything that we do that disrupts blood flow to an already poorly perfused area could cause need for amputation and further damage down the line. So really take into account the responsibility you're putting on the team with starting an IV in somebody's foot or leg if it's for a diabetic patient. IO access and the needles that we carry the 45 millimeter yellow hub, the 25 millimeter blue hub, and the 15 millimeter pink hub. The pink is supposed to be for pediatrics, blue is supposed to be for adults, and the yellow is supposed to be for bariatrics or the humeral site. The humeral sites are at the top of both arms. At the top of both humeruses, not just your arm. Then there's the proximal tibia, which is you find the bump in your knee, 2 fingers down, 2 fingers in. And then their distal tibia, which is just above your second finger if you put it on the medial malleolus. I wanted to throw some stuff in here about specifically flow rates through a humeral head IO. We have not had a ton of attempts or successes with the humeral head IOs, and after a couple of conversations with some people, I think that confidence needs to be built in how to find your landmarks for this. We're all very used to finding our landmarks with the proximal sites below the humerus and the legs. We're not as used to it with the humerus, but that doesn't mean that we shouldn't use it. Comparatively, in the humerus, the time to infuse 1 liter is 17 minutes, according to this study specifically. Time to infuse 1 liter is 17 minutes versus 33 in the leg. Now, obviously, that's slower than an intravenous angio, but if this is what we have, then we're not able to start an IV on everyone. Understand that it takes about half the time to get your volume infused. Here's another graph, different study. The humerus site, the mean flow rate was about 57.1 mLs per minute versus the proximal tibia was 30.7 mLs per minute, and your first attempt success rate was higher in the humeral head. So again, showing of almost double the flow rate through the humerus site. And then the third study showed that a 15 gauge humeral IO with a flow rate to gravity is 80. Time to infuse a liter is 13 minutes versus the tibia site. A flow rate is 70, and then time to infuse is 15 minutes. This last study was done in cadavers, so overall, you can see that with the last three different graphs, the humeral compared to the tibial site is it's faster. It's vastly faster. It's quicker to the heart. It's quicker for fluids, and overall, as far as timing goes, it's going to be better for an arrest. I loaded some videos into the target solutions. These are them. You can't really click them in the PowerPoint. Please feel free to view those. And then thank you very much.